there was a patient, young guy who came to DOC program from West Texas. And of course, when we treat the patient, we always assume they're conscious, they can hear us, they can see us, they can understand us. But still, I have to remind myself to stick with it because they're look unconscious. So maybe I was talking to him about like how my husband was training in West Texas and everything while I was assessing him and everything. And then later in the course, he had like VP shunt place, and then he started talking after a while. And then one day, all of a sudden, he asked, how's Ed?
Wow.
What did you just say? You're Ed, your husband.
Mm-hmm.
I was like, did I talk to you about my husband? So there are two thoughts come to my mind. Like, what else have I told you? Right?
Tell me everything.
Tell me, what did I tell you before? And then what secrets do you know about our staff now, right? So those are things that I told him when he didn't look to be conscious at all. So like, again, those moments that gives me chills, right? So I always recommend when I have trainees, like residents and fellows, you always want to assume they can hear us, they can see us, they can understand us.
Welcome to The Summary, a podcast from Mary Free Bed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
Today we're going to talk about brain injury and specifically disorders of consciousness. And we have a couple of very special guests with us.
Super special guest for me. They're actually both my very, very good friends. And one of them are actually my high school roommate. And we shared a bunk bed for like 3 years together and went to summer school together, all of those things. So very near and dear. And we're going to have them actually introduce themselves today.
Hello, nice to meet you. Thank you so much for having us today. And my name is Jin Woo. I am the high school roommate of Eunice. And then I'm currently working at Baylor College of Medicine in Houston, Texas. And I'm a physiatrist specializing in brain injury with special emphasis on disorders of consciousness. Very nice to meet you all.
Hello, everyone. My name is Bei Zhang. Very honored to be here as well. I'm currently a PM&R physician at Texas Tech Health Sciences Center. I did my physical medicine and rehab residency at UT Houston, where Dr. Wu was my senior resident at the time. And then I did a brain injury medicine fellowship at Spalding Rehab Hospital. I also worked with Dr. Sinsky a little bit in the International Rehab Forum, supporting PM&R education in South Africa. So great to be here.
We're so grateful that you joined our international team. We're absolutely grateful.
Appreciate the invitation.
So why don't we start with how do we actually define disorders of consciousness and the levels and the types of things we see?
Of course, yeah. So disorders of consciousness is a state of altered arousal and level of awareness. So it can be from any type of acquired brain injury. When we say disorders of consciousness, a lot of the people picture traumatic brain injury. In fact, people can be in a disorders of consciousness state from anoxic brain injury, previous like stroke, encephalopathy. So when we talk about disorders of consciousness, we're talking about anyone with acquired brain injury that led to altered level of awareness and arousal.
Yeah, actually, so I think the meaning of DOC, disorders of consciousness, sometimes can be more complicated than that, considering, its implications in ethical, legal, philosophical domains. For example, from a philosophical point of view, some philosophers believe that they define consciousness or describe consciousness as a subjective qualitative experience, like how would one feel like being themselves. That's how philosophers view consciousness. So from that perspective, the disorders of consciousness may mean the disorders of altered subjective experience. So it depends on, I think that there is a broader meaning of it. It's more complicated than it sounds like because we don't have a really solid definition about consciousness. But right now, clinically, we view disorders of consciousness as a profound disruption in arousal and awareness of the patient.
And it sounds really just like it sounds a really complex thing, right? What is even consciousness and how do we define that? But with that, my assumption is there's going to be so much like misdiagnosis and misunderstanding around it. What's your experiences with that?
Yeah, just like you brought it up, consciousness is an internal state. So there's really no way of directly measuring level of consciousness, right? So we have to go by the proxy, which is the behavior responses. You know I'm conscious because I'm talking, I'm moving, I'm interacting with you. But anyone who had acquired brain injury, there's leading to like severe neurological deficit where they cannot show you what they can do or show their internal state. It becomes very challenging to know where they are in terms of level of consciousness if they're not interacting with you readily because they're weak, they're too weak, having language deficits, things like that. So there could be a lot of confounding factors. So some of the literature says there's up to 40% of misdiagnosis rate where people who are labeled as unconscious, when they're actually looked into, they're conscious in fact. So that gives me chills, right? Like,
that's so high.
Where in the medical field would tolerate 40% of misdiagnosis rate? Like, for example, if we have 40% misdiagnosis rate in cancer, that's not going to be accepted, right? So that's also one of the things that reason why we advocate for rehab for disorders of consciousness patients, because there are a lot of thoughts that people who are not able to readily follow your commands or anything, they're not viewed as rehab candidate, which is why they're also missed out on this opportunity to come to rehab and marginalized in the society.
And this has been brought up to the field's attention, I think, more and more over the past few years or over the recent decades. So more and more research are looking into how to optimize the diagnostic process. For example, advocating for using standardized, validated evaluation tools like Coma Recovery Scale revised. And also, we're advocating for kind of repetitive assessment. It's not one-time assessment that can give us a solid answer, and these type of patients, they need to be evaluated in a systemic manner repetitively, and because their status may be changing over time too, and on top of everything, there are newer technologies being developed as well. For example, functional MRI, some EEG, task-based EEG paradigm that can help further identify signs of consciousness in patients without solid behavioral evidence.
So you are looking directly into brain activity, bypassing the motoric behavior responses. So those are being utilized in research setting these days.
So to diagnose more accurately, you're using standardized measures, some functional imaging, maybe some time, and what else might you do to better diagnose these patients?
So number one thing would be bedside evaluation. We observe patient. We trigger the patient to show us responses. So we can also talk about like what each level of state of consciousness mean. So like we start with comatose state where there's no sleep-wake cycle. Patient is just in sleep. And then they can be merged to vegetative state, or it's also called unresponsive wakefulness syndrome or state. So those people start showing signs of arousal, meaning like their eyes start opening on their own or to stimulus. But there's no signs of awareness. There's no interaction. They're just awake. They might have some reflexive output, but not intentional automatic movements or anything. Then they can move up to minimally conscious state where they start showing some signs of awareness, visual tracking, visual fixation, some command following, even if it's inconsistent, some automatic motor response, let's say like scratching the face, going after trach or peg, because there's no reflexive movement that leads you to it. So those are like very subtle signs that already tell you they are conscious. So we try to look at all this, look for the signs of consciousness, like any behaviors. Sometimes we trigger them. We just pinch their finger and to see how they respond. If they come get you, that's also localization, which indicates consciousness versus posturing or just having reflexive withdrawal. So we do a lot of assessment at bedside. When I first admitted a DOC patient, those are the part of my physical exam. Even in that, just observing, if I say I have a person who come with a mitt, come to DOC program, I already know they're doing something they're not supposed to do. I know they're at least minimally conscious, that they're doing something, right? So sometimes it could be that easy to pick up whether someone's conscious or not, even from the doorway, even if before I touch the patient. So a lot of observation would trigger them for responses. And then the next part would be what Dr. Zhang mentioned, the JFK Coma Recovery Scale, which is a standardized testing to look for signs of consciousness. So we perform it like twice a week, a series of testing, because these patients fluctuate a lot. If you pick up the time that's not just best for them to perform, you may not pick up the signs of consciousness. So we repeated with multiple sets of eyes. So those two are the main means of assessing or look for signs of consciousness. Like functional MRI, EEG, nowadays I think it's more used for in a research setting. So it's not part of the standardized care yet, or I mean, of course, those are expensive, so we may not get it approved by the payers either. But I hope it becomes more of comes into use in the near future.
My understanding was with the CRS, even though it's a standardized test, there's so much variability in it.
I think it is a standardized, validated assessment tool, and there are a standardized protocol that all the assessors need to follow. But the caveat is it needs to be customized to individual patient, in my opinion, because some of the commands that's being used or some of the objects that's being chosen to be used in the assessment paradigm may matter. So, for example, I think Dr. Wu can talk about a patient who was used to, drink alcohol and then.
Oh yeah. So part of
Yeah.
the yeah.
Yes.
So part of the assessment of the Coma Recovery Scale Revised is to show functional object use. So even a patient who doesn't look conscious, we still try it as part of the assessment. So we hand over an object. So usually we use like a ball and a pen and then ask them, hey, show me how to use a cup, show me how to use a pen. For some people, we just have to use something salient for them. We had a patient who was a heavy smoker because we didn't get anything with the just typical object that we use. So we actually made a fake cigarette out of a straw.
Why did it have to be fake? Why couldn't you just get a
I don't know.
Okay.
Just
You're in the hospital.
We're not promoting actual
we're not
smoking.
promoting. So we cut it. We colored the end with a brown like marker. And as soon as we gave it, she just grabbed it just like how it's supposed to be, brought it to the mouth.
Really?
And then like other patient will bring like a wine glass who's a really like wine
heavy drinker?
So like it goes straight to the mouth.
So the cup didn't work. Coffee cup
Cup
wouldn't
didn't work.
Wow.
The wine glass worked. I mean, we could have brought the wine bottle, but we didn't, of course, for the same reason. But so just like Dr. Zhang said, the standardization is using two objects, and then the patient has to demonstrate how to use the object twice each. So it doesn't matter what object we use; it's still under the standardization, but we actually try to trigger the response as best as we can by using like salient object. I even donated my husband's Xbox game controller. Because that might also trigger some response out of like young kids or any like people who play game at home. So I just took it. I'm taking this. So I put it on the CRS-R kit so that we can also utilize those.
Was he really sad?
Yeah. So to piggyback on those stories, for example, younger kids, teenagers, if they unfortunately ended up in a DOC state, and sometimes during assessment paradigm, we can hand them the iPhone so that sometimes it triggers spontaneous swiping action. And in elderly population,
that's a reflex for teenagers, right? A primitive reflex.
It's a more complicated reflex rather than a simple tender reflex. And then in elderly population, the iPhone, the smartphone may not work for them, may not trigger any responses. You want to put a flip phone in their hand. They may start trying to... Yes, they may try to start flip it up because they're more familiar with, a different type of phone. So I personally think these type of subtle things matter in designing a standardized testing. So that's worth mentioning.
That's a good idea. I never even thought about that.
Yeah, but part of it is really just taking the time and trying things and trying to get something out of these patients and like you said, going back several times because, they kind of go in and out or the sedation may be different. So it takes a little time to get that. But then that's helpful because then I assume that helps get them into a more intensive rehab setting.
Right. And I have an interesting story to share, talking about object use and misdiagnosis, right? So I had a young girl who was admitted to DOC program, labeled as vegetative, unconscious, and she looked to be like that. And then part of the CRS-R, of course, we handed over a pen. And we asked her, show me how to use a pen. And she just grabbed it and then started scribbling in the tiniest font you can imagine. So like, oh yeah, that's functional use, but we didn't even care to look what she wrote because we thought it was a scribble. And then it looked like letters. So we brought the paper close, and then we had to look really closely. She literally ordered her Starbucks coffee.
No way.
What was her order?
She used to work at Starbucks.
Oh.
So not just like caramel macchiato. She said, ice chai latte, extra ice with lid and a straw, with sleeve, or a double cup, something like that. Very, very detailed. And then later, she also wrote numbers. We had no idea what it was. Later, when I followed up with her in clinic, the parents actually told me that they found out what the number was. That was her employee ID. So it can be as crazy like that. Just we got to give them opportunity to show, even if you don't think they're going to be able to do it. So yeah, that story just stuck in my head. I always share that.
Yeah, there are so many patient stories like that. But remember, those patients were labeled as DOC on admission, meaning acute care providers or the diagnosis was believed at the time the patient was not responsive, was not able to do anything, and had a doomed future, essentially. That was told to many families at the time. But during the rehab process or in a specialized DOC rehab program, many of them are found to be conscious or even fully conscious, for example, being able to make orders, communicate. But the point is, many of these patients are very motorically impaired, and that's the reason they look so bad in many clinicians' eyes. And we have to recognize and resist some of our intuitive kind of impression or bias and give them a fair trial or give them opportunity. It's very important during the assessment process is to set them up for success. We need to provide them an optimal environment for them to function. They may have only trace minimum control of one part of their body. For example, sometimes it's head and neck. They cannot move all their limbs. They cannot just raise their hand, or tell you yes and no to answer questions. But they may be able to move their head and neck a little bit to indicate yes and no. But we got many solid answers, consistent yes and no answers in terms of, to answer questions. So I think that's worth mentioning. That's worth clinicians' attention, and also setting them up for success also involves an optimal position. For example, not putting them just in a bad position, laying in bed, because people naturally fall asleep when we're laying flat. That's just the human nature. So it would be better for them to get out of bed, sitting at the edge of mat, or sitting in a wheelchair, or even standing up with assistance. For example, the weight reduction system or standing frame, just to stimulate their arousal and support their functioning status. We actually had a recent research suggesting the correlation of better performance in CRS-R in an upright position comparing to a laying position. So we hope to advocate for clinicians' attention in these domains to appropriately assess the patient's level of consciousness. On top of everything, I think the treatment of DOC or convoluted with the assessment process too, because many of these patients have reversible situations. For example, infections going on, urinary tract infection that make them drowsier or unable to respond to questions than their best state. Many of them may have some clinical seizures that's worth investing and managing. Many of them develop hydrocephalus that may impair their functional status too. So that needs to be looked at and treated.
Yeah, so that's one of the reasons why we're so bad at assessing level of consciousness. So those are reversible causes. those are the conditions that can bring down the level of consciousness, but it's treatable, reversible, like subclinical seizure, any new intracranial process like hydrocephalus, trephination, infection, a lot of sedating medications. By the time they come to rehab, they're on a handful of sedating medication for whether it's storming, whether it's seizure. So we got to look back and see if it's still needed, reassess, and then try to win them off as much as possible. So there's also another group we call confounding factors. Again, with the brain injury, they're very weak. They could be spastic. They might be contracted in their joints to show us motor behavior. What else? If someone is aphasic, they may not be able to follow commands, even if they're conscious. And if they have critical illness neuropathy or myopathy, they're also very weak. So we have to be mindful of those confounding factors as well. So thinking about that, you are always at risk of underestimating the level of consciousness all the time. So I think we just need to be reminded of that too. And then even myself, I mean, those patients who are in there, very deceiving, they look unconscious, but while in fact they could be conscious. There was a patient, young guy who came to DOC program from West Texas. And of course, when we treat the patient, we always assume they're conscious, they can hear us, they can see us, they can understand us. But still, I have to remind myself to stick with it because they're look unconscious. So maybe I was talking to him about like how my husband was training in West Texas and everything while I was assessing him and everything. And then later in the course, he had like VP shunt placed, and then he started talking after a while. And then one day, all of a sudden, he asked, how's Ed?
Wow.
What did you just say? You're Ed, your husband.
Mm-hmm.
I was like, did I talk to you about my husband? So there are two thoughts come to my mind. Like, what else have I told you? Right?
Tell me everything.
Tell me, what did I tell you before? And then what secrets do you know about our staff now, right? So those are things that I told him when he didn't look to be conscious at all. So like, again, those moments that gives me chills, right? So I always recommend when I have trainees, like residents and fellows, you always want to assume they can hear us, they can see us, they can understand us. I mean, we could be wrong, but then the vice versa, it's more detrimental, like treating them like they're unconscious while they're conscious, right? So I also wanted to share that story with you guys.
It's like being a detective, right? It's just like, and being curious constantly and going against your own thought process of like, no, like.
Yeah.
Wow.
But I'll also tell parents sometimes, you know what, we don't know if they're hearing or understanding, but talk to them, not just to figure out what's going on, but just, tell them how everyone's doing, things like that. Because, they might be paying attention.
Right.
You just
So we
don't
also
know.
educate the family. If there's any conversation that you don't want your loved one to hear,
Yeah.
take the conversation
Yeah.
outside the room. When we hold family conference or rounds, I ask them to step out so we talk outside. It's not like I'm withholding any information from the patient, but sometimes how we get to the conclusion decision, they may not want to hear it. And it's also unfair for them to hear it when they're not able to participate. So
That's a good point.
Yeah.
I can see how hydrocephalus being like so common in this patient population, if they're elderly, had a stroke, a lot of cerebral mass loss in the beginning. How do you differentiate though, and how do you advocate for this patient that like, yes, I do think this is hydrocephalus, and how do you manage that?
Right. I mean, the first trigger would be the imaging findings. We see large ventricles, and you kind of have to see the nature of the brain injury, like traumatic or subarachnoid from aneurysm rupture. They're at high risk. Intraventricular hemorrhage, things like that. And then, especially in disorders of consciousness level, we also perform large volume lumbar puncture to see if they will have clinical response or changes, improvement. But then the lumbar puncture itself is also a limited study where if the patient has positive response, we know they're going to benefit from VP shunt. But it's a type of study that if the patient doesn't change, it doesn't give us any information because those people may still benefit from VP shunt. So sometimes it's still hard, even after the diagnostic test, whether the patient will benefit from the shunt or not. It is, in the end, a brain surgery, so there are risks and everything. It's not an easy decision to make. So we always go over the risks and benefits of the surgery, but I always bring it up, the risk of not pursuing anything, right? Or we just content with where we are, or do you want to keep looking for anything that can potentially give them more potential for recovery?
When do you go for the large volume lumbar punctures?
So I typically do it while they are still inpatient rehab, but it can be also coordinated as outpatient. But it's a lot easier to do it inpatient because we also do pre and post trial. With PT, OT, and speech neuropsychology, we do CRS-R before and after to pick up the change. Because these sorts of constipation, they're not walking, they have urinary incontinence, they have memory deficits just from the brain injury, not just from the hydrocephalus, right? So we actually have to look at their responsiveness, their, posturing, anything next. If they were storming, does that get better? Head control, even subtle signs, we have to look at everything. So it's a lot easier to do this inpatient than outpatient because they don't have like primary therapists they're following for the patients for a long time to know their baseline.
It's actually very challenging in diagnosing hydrocephalus right now after TBI or after any type of catastrophic brain injury to justify, okay, this is, the functional deficits is related to hydrocephalus rather than a pure, for example, brain atrophy as a result of the severe brain injury. So but based on what we observe in the clinical setting, so the typical triad of communicating hydrocephalus is like cognitive deficits, urinary incontinence, and gait abnormality. But those might be just simply a consequences from the severe TBI to begin with. And so typically what we observed in the rehab setting in those patients, if we are worried about whether hydrocephalus is playing a role, include the patients, it's typically present more like having Parkinsonism, like they may present as they're moving less. They may present as having apraxia. Movements is super slow. Processing speed is very slow. They're unable to answer questions as they used to be. So typically, acquired brain injury is a stable state. The patient should be getting better with rehab efforts rather than keep going downhill. So that may be a sign. If the patient is regressing rather than, advancing or plateauing at a certain level, you may, if there is enlarged ventricle involved in imaging, you may want to consider those. And then, the gait is not really, evidential in many cases to begin with. They're not ambulatory at the time, like, community residents. Urinary incontinence is just simply very, very common after a severe brain injury. So, but I think looking out for akinetism, apraxia, slow processing speed, signs of Parkinsonism, those are the signs that we are seeing more in the rehab setting. And in the DOC population specifically, I think just weighing pros and cons, having a large volume LP trial and see if they can become more responsive, motorically or verbally, I think it's worth a shot. Considering, pros and cons, that should be, the pros should be outweighing the risk. But considering pursuing for the VP shunt placement, a serious conversation needs to occur with the patient's surrogate decision maker and also the neurosurgeon, to have all the information together to help them make the decision.
How about, so a lot of the patients with traumatic brain injury will have a craniectomy, and does that come into play when you're at a DOC level? Like, do you see changes when they have the cranioplasty, or do you push for a cranioplasty to see if there's changes?
Yeah, so we still accept the patients in a craniectomy status, although we would prefer to have cranioplasty done than have them come to rehab. Because some people's, our neurosurgeons say about maybe 40% of the time, people can actually perform better after cranioplasty. So it's still hit or miss. But whenever we have a patient who has limited like progress, we always think, is it because we're missing bone flap? So there's always a thought of that too. So
I think we do see people getting better after cranioplasty for whatever reason. Sometimes
even at the DOC level.
Yes, I think so. Yes, yes, for sure.
Yeah, but when they are missing bone flap, they might also play a role when we want to pursue the VP shunt, even if there's a indication for hydrocephalus. Sometimes having a VP shunt without cranioplasty, it can also cause overdrainage or trephination pretty easily. Then we have to adjust the shunt nonstop until the cranioplasty can be done. So it kind of, I think, plays a role in terms of timing of the VP shunt, even if the patient seems to have hydrocephalus because of that.
Yeah, it is a really complicated situation. I've had a couple patients with neurosurgery that after the shunt placement, it's not a done deal. It's not about simply putting a shunt. It's also about shunt adjustment. So many neurosurgeons are worried about subdural hematoma if we decrease the pressure setting on the shunt too quickly after surgery. So many of them like to go slow just to prevent, significant consequence from, reducing the shunt and draining, the CSF too quickly, which is very, very reasonable. But I think clinicians, especially rehab providers, practitioners, needs to be aware that, having the shunt placed may not be the end of this treatment. You have to make sure the shunt is optimally adjusted over time, because typically neurosurgeon won't adjust the shunt, after a couple of weeks or a couple of months, and that needs to be followed up on. If the patient's reaction or responsiveness has not been improving, it might be because the shunt has not been adjusted rather than, simply having the shunt placed.
So what do you do when you ruled out hydrocephalus, the shunt is proper, everything's looking good, but the patient is still not doing too well, not improving? What's their next step that you go to?
Go ahead.
To add to that, I'm wondering about medication management at different stages.
Of course. So usually, even if there's a hydrocephalus, the positive cases that I've had, several cases where they had dramatic change, it didn't really happen right away. It still took several weeks until I started seeing the change. Sometimes they also required VP shunt adjustment, just like Dr. Zhang was mentioning. So I don't expect to see a change right away.
Majority of the time.
Majority of the time.
Okay.
So when we go for VP shunt, I also educate the family for a realistic expectation. I don't expect your loved one to change significantly right after the shunt. It might take still time, but in the meantime, we try to continue with conventional like rehab intervention, like therapy, medication trials. Like we do definitely have pharmacologic interventions. They're not strongly evidence-based at this time. There are only a couple that are evidence-based, but it's a lot of trials and observation, because also at different stage of recovery, their needs for medication may also change. So in the beginning, when they're hyper-aroused, like really hard to arouse, we'll be focusing on arousal medication. And then once they start to stay awake, then we may focus on like attention, processing speed, initiation with neurostimulant. And then there are also like zolpidem trial that's out there. That's one of the medication that was studied. It's very low likelihood of having paradoxical response to zolpidem. But this is a life-changing intervention for those small subgroup of patients. So we always try that for all the DOC patients. What else?
Yeah, I totally agree. Those are basically the dopaminergic agents would be the go-to to help, facilitate the brain's functioning. It is a major neural chemical in our brain. And then, as Dr. Wu said, majority of them are not really evidence-based. We have to acknowledge that. Basically, we're borrowing the understanding, the concept of the medication, the understanding of the mechanism of action of these medications from neurology, from psychiatry, to be applied in the rehab setting. So we're hoping that more study will be done in the future. Right now, amantadine is the only one who had a really well-designed randomized controlled trial led by Dr. Giacino's team that showed it helped hasten the recovery pace in the acute DOC patients. So it's definitely worth a trial. Other options may include methylphenidate, modafinil, caffeine pill. So the whole idea essentially is to help promote arousal and awareness by using these medicine, and then you weigh pros and cons, in the event without solid evidence. How much harm may the medicine cause, or, how much benefits may the patient get from using this medicine? So in most case scenario, the benefits would outweigh the risks with close clinical monitoring of patient responsiveness. So yeah, that's the reason. It's kind of the concept or the philosophy in rehab of using pharmacological agents is, You start low, go slow, but go. Give it a shot. If the patient's condition improves with the use of these medicine, it is a life-changing event for them. And it's the same idea for Ativan and Ambien trials as well. So there are a very small group of patients that react paradoxically to Ambien, zolpidem essentially, and lorazepam. So basically, they wake up, they started reacting, they started moving, they started talking after taking these medicines. So in the rehab setting for DOC patients, if they are a responder, we're using them as a neurostimulant, as a cognitive enhancer, essentially. We schedule them during the daytime to help promote their cognitive functioning, physical functioning, and therapy participation. It is worth a trial. Worst case scenario, they just go to sleep for a couple of hours and the next day is a new day. So it wouldn't have long-term consequences in a negative manner. But if they are a responder, it's going to be a life-changing situation for them.
Let's say you started amantadine and you're like, oh, I'm not sure if this is helping. You're going up and up and up. One, when do you stop and say, okay, we definitely failed at this point, like the length of time or the dosing? And then if you're saying like, okay, now I'm going to try a different medication, do you add on to that? Or do you completely substitute out? Like, what do you guys do?
I would say it's case by case. If the patient is tolerating amantadine okay, then if I'm not seeing the results that I'm expecting, I might actually add more, because sometimes they might need a combination of pills or medication than just one agent. But of course, if the patient does not tolerate amantadine for severe hypotension or something, then I'll get rid of it immediately and then try a different agent. But I think it's case by case.
Yes, it's to me, it's more based on what you observe in the clinical setting and what problem or what benefits therapists report to you. They are really a very valuable source to obtain information regarding how the patient responds to the medicine. So sometimes it's, for example, if it remains to be an arousal issue, I may want to use medicine to promote arousal more, to wake them up to begin with. If it's more of an attention, the therapist feel like the patient is just all over the place, they cannot focus. So methylphenidate typically is a very good go-to, or the neurostimulants category is a very good go-to to help them focus a little bit more. So it depends on really the clinical assessment of the patient's situation. There are nitty-gritty small differences in the mechanism of action, which receptors are actually hitting on, how the medication is actually working in the brain, to kind of try to modulate the regimen.
I'm just fascinated by the Ativan trial, which I've not heard of in DOC. And you do an Ativan trial in catatonia, at least in kids.
Right.
And, is it a similar mechanism, or do we know what's going on?
So one of the theories I think we have is maybe we're treating some of the catatonic features in those patients who may have acquired a secondary keratin, not just psychiatric diagnosis. So, we're fascinated by the results too.
So it's like almost like a little light switch when it happens?
For some patients.
For some patients, few patients, not all.
We actually have some interesting results. So we actually we did a retrospective chart review essentially on the trials that was done at our institution at the time. So among the patients with hypoxic ischemic brain injury, nearly 30% of them responded to Ativan.
That is a really
but
high
that was,
percentage.
Yeah, it's still a small study. The total trial that we did in those patients was around 40 to 50. So, 30% of them really responded. Well, again, this is not a design trial. Like we have like strict inclusion and exclusion criteria. It was literally based on the clinician felt at the time, okay, it's worth a shot. Let's give it a shot, and then the patient responded. That was kind of the real clinical data, but it's not in a controlled manner. But it kind of gives us some ideas about, hey, this medicine may actually work. It's worth going for the patient. So I think in those hypoxic ischemic brain injury patients that they did not really respond to zolpidem. And interestingly, in TBI patients, more patients responded to zolpidem than lorazepam.
What's the thought behind that?
We don't really have a very good explanation, unfortunately.
The anoxics, what kind of level were they, and what kind of responses? What's kind of an average response that you saw in the responders, I guess?
And then like how quickly?
Yeah.
Yeah, typically the effects was observed like within an hour or two. Like we schedule therapy sessions after 30 minutes of medication administration. So that's when the responsiveness was observed. And some people started talking. Some people was able to move parts of a limb more to, respond to commands. I think those are the considered positive trials because there are significant functional changes that were not observed during their entire previous rehab stay.
Even the duration of action, I think it varies by patient. I had a patient who had a positive response for like several hours and that's it. I also had a patient who had a TBI. We tried lorazepam, maybe mid-morning or early afternoon. And the next day when we saw the positive response, we were like, yay. Next day I rounded and the wife complained that she couldn't sleep because he kept talking until 11 p.m. It's like, oh, okay.
Too stimulating.
Yeah. So.
Yeah, it's very interesting. I think we don't have a very good understanding of it. Potentially, hypoxic ischemic injury affects a wider areas of the brain. And then Dr. Nicholas Schiff actually proposed a theory like why zolpidem worked is because of its inhibition to the inhibition pathway. So it works in the missile circuit, and then it inhibits the globus pallidus interna to inhibit the thalamus function. So basically, it stopped that inhibition. So thalamocortical tract started to work. So it's still very interesting. There are many intriguing phenomenon in this type of population, and that's kind of what drove me into the field.
That's fascinating.
Yeah, and one of the reasons why it's so hard to study medication effect on recovery after in a DOC patient is because we don't know how much is natural course of recovery too, right? Unless you have a control study to compare, but they're all getting intervention like therapy and everything. So I think that's one of the reasons why we have such limited data on what medication work, what needs to be tried, in what manner. Yeah.
Well, it's nice to have some medications that you can at least trial that give, in some patients, a quick response. I use amantadine all the time in these patients because there's good science, but I never really notice a change. I don't know what's recovery and what's amantadine, but there's good science. But now, there's some other medications that we can trial. I don't really think of trying Ambien early on in these patients.
Right.
Sometimes it's a matter of time too. So if a patient is not responding to Ambien or Ativan at the time, it doesn't mean that they will never respond to it. Actually, in our institution, we're doing repeated trials. Well, again, we don't have a protocol or set timeline, like when would be the best time to run these trials. It's more of a clinical judgment at this time, but it's worth give it a shot later on, a few weeks, a few months, because the neuro recovery essentially is a dynamic process. So the patient may respond to it later on, but just keep these thoughts in your mind. I think that would be playing favor for the patient's recovery process.
And I also want to add, like, there are also beyond pharmacologic intervention, how to wake them up. We mobilize the patients like crazy. We get them out of bed as soon as they get the wheelchair delivered to bedside, we sit them up, we stand them up, we work on core sitting balance, or even if it's all dependent. That's also how we wake them up too. We may put them in the body weight support gauge system device and everything to make them move and go.
About auditory sensations, music, you have people talking to them.
Yeah, any sensory. We
All
also
that.
encourage like effective tactile stimuli too. We touch
Okay.
the patient a lot from therapeutic purposes. But what they're lacking too is effective touch, right? So we always encourage the family, hey, just hug them if they're a hugger. You just treat them just like how you used to interact before this injury. So yeah, sensory, light exposure. When you're not in therapy, take them outside. Yeah.
How about, we always talk about having a quiet environment, but what if their favorite music is heavy metal rock? Do you give them that?
Yeah.
Or-
I say go for it. You just got to watch their response. If they seem to
Okay.
be in distress, storming, then we know it's not the fit right now. But I say go for it. Yeah.
So what are the main reasons how do we advocate for our patients? Because we want them in inpatient rehab, but there's this constant struggle. Like, how do you navigate that?
Yeah, it is still a struggle in all domains, but I think definitely building the rapport connections with the acute care clinicians is very, very important. Get them to gradually understand, okay, these patients may deserve a chance, maybe too early to tell anything for sure. So kind of to me, I feel being a consultant, building that report, getting these information from our perspective across to them, that's a very important first step to begin with. And then, constantly involved in acute care process, helping them manage some of the reversible causes and potentially initiate some of the cognitive enhancers early on, for them to see a positive response of these rehab approaches that may be, more convincing to them, like, okay, actually, I've seen this working, so let's get them to inpatient rehab. Right now, one of the biggest barriers is actually insurance coverage. Based on the current Medicare, Medicaid guideline, the patient needs to be able to, quote unquote, actively participate in 3 hours of therapy 5 days per week. That's being used by many insurance carriers to deny the case because they believe that patients with DOC cannot actually do anything. They cannot participate, and they have doom prognosis. They won't benefit from inpatient rehab. So we've been doing some retrospective study from the DOC program in our institution to try to demonstrate inpatient rehab is actually effective in helping them, recover. Among those acute DOC patients, meaning DOC happened within 28 days of the inpatient. The inpatient rehab admission occurred within the 28 days of their severe brain injury. 90% of them emerged from minimally conscious state, and 100% of them had measurable FIM score improvement, meaning measurable categorical changes on the FIM score. 60% of them, by the time of acute inpatient rehab, only required moderate assistance. So that, considering how they were looking, what was the prognosis being determined, and how much they advanced, even if it's moderate assistance, to me it's still very significant. Over 90% of them during the acute inpatient rehab course, they were able to get decannulated, and around 70% of them were able to be started on an oral diet, meaning they can eat by mouth,
Even if it's for pleasure. Yeah.
Even if for pleasure or a modified, diet regimen. So to me, yes, I would definitely want to try to, present these data, try to get our perceptive rehab approaches across to the acute care, and try to hopefully, get more buy-in and
Right.
and.
But you
or
have to
referral.
go ahead.
Well, plus you're trying to help the family be able to physically manage this patient at home and get the right equipment.
Yeah, surprisingly, a lot of our patient population from DOC program discharge to home with family training.
Yeah.
So that's another thing that we advocate, like when we have to do peer-to-peer with the payer source and everything, instead of insurance having to pay for another facility, our patients do go home. We order the DME, the equipment, we train the family so they know how to care for their loved ones, how to interact with the loved ones at home. And we probably are able to reduce the likelihood of hospitalization because we teach them on positioning, how to prevent skin breakdown, how to prevent contractures, which would have a lot of cost in the future if they do happen, right? And we also have to acknowledge the huge gap between acute care and then rehab. So only time the acute care healthcare professionals see their patients back is when they're not doing well. So they're also kind of biased very reasonably that these patients do not well. And then we're also biased. We see the outcomes, but we don't know how bad they look when they first got to acute care hospital. So when Dr. Zhang was a resident and was a fellow, we actually created a program called Thank You for the Referral, meaning in an attempt to close the gap. So what we did was patients who recover well enough to express, whether non-verbally or verbally, with the consent, we record their videos saying thank you for the referral, not to blame them for holding family conference to pull the plug or anything, but very nice way to like acknowledge, hey, this is what your patients look like. I mean, you can always tell them, hey, your patient's doing really good, but it's nothing compared to when you actually see the video of it, right? So we take the videos and send it back to the acute care, especially the social worker, case manager, who are the ones who manage the discharge planning. So that they can actually see with themselves what the patient can look like. I mean, I'm not trying to say that everyone who come to DOC program has really great outcomes, but there are a good handful of patients who have good outcome, will go back to college, have work, have a job. So that's
we have
one
so
thing.
many stories.
Right. And then there's also, but because of that limitation where the only time they see their patient back is when they're not doing well, there's also like self-fulfilling prophecy where what they believe actually becomes the outcome because of the belief. Like if they don't think they're going to do well, they might be more likely to talk to the family about pulling the plug or withdrawing this life-sustaining therapy. And then it leads to the poor outcome, like mortality rate. And then when the data publish, then it actually reinforces their belief, right? So another topic that we really like to want to discuss is disability paradox. It's a phenomenon where able-bodied individuals can never really estimate accurately the quality of life of disabled individuals.
Disability paradox.
Okay. So there was a study among locked-in syndrome patients, and they had those patients self-report their quality of life, and they also recruited people, normal individual without disability, to estimate those patients' quality of life who couldn't move or independent with their daily life and or mobility and everything. There was a huge discrepancy how they measured it. So, I mean, we try our best. With good intent, we try to put ourselves in their shoes. But it's such a foreign thing for us to even imagine. So, because when you have like in an acute care setting, if you have a family conference, you're going to talk about meaningful recovery, quality of life, even if they survive the catastrophic injuries. Even if they improve a little bit to be able to non-verbally communicate or anything, they might be still dependent on others for ADLs and mobility. Is it a life worth living? But as third person, it's almost impossible to estimate their quality of life. Whose quality of life is it anyway? Like meaningful to whom? To you or for the patient, right? So that's another thing that we wanted to kind of discuss when it comes to distance of consciousness.
Yeah, that's interesting. I bet the difference would be even greater with kids with cerebral palsy, because they've kind of grown up, that's their life, and they have a great life. And, outsiders outside of their family would probably judge their quality of life as terrible.
Right.
Yeah.
Wow, that's such an interesting conversation. Oh my gosh, it gave me chills when you just talked about like disability paradox and how that's different, how much it is like, yeah, who are we to you just don't know what you don't know in the end.
Right. Yeah.
Well, it's been a fascinating discussion. I'm thinking about a lot of things now, so you made me put my thinking cap on and go back and look up some more things. Thanks a lot.
Thank you so much.
But thank you both for joining us and sharing all your expertise.
Are there any other last minute things you wanted to share?
No, I think it's about giving them opportunity. Yeah.
I want to ask you one last question. Does Yuna snore?
No, she didn't. At least
Not back
in high
then.
school.
Not back then.
Okay.
Not now I do.
Yeah, she might toss and turn. Then I was like, stop, my bed is shaking.
I know, I used to move a lot, right? Yeah.
Yeah. Well, again, thank you so much for having us. It was such a pleasant experience for us.
Yeah, thank you very much
Thank
for
you.
having us
Guys.
and talking about DOC.
Great.
Appreciate it.
Thanks for all the work you guys do.
Oh, thank you.
You're watching The Summary, hosted by Dr. Yuna Sinsky and Dr. Doug Henry.